It's my pleasure to introduce our first two speakers. It's a team presentation between Dr. John Lynch and Dr. Steve Mitchell. Dr. Lynch is the medical director at Harborview Medical Center, infection control, antibiotic stewardship, and employee health programs. Has a clinical provider for outpatient and inpatient infectious disease cases. He's completed a residency in internal medicine, specialty training in infectious diseases, and an MPH during his fellowship. Dr. Lynch's research interests include healthcare-associated infections with a focus on prevention through education, behavior change, and clinical care. He leads UW School of Medicine's medical microbiology course and teaches on the subject of infectious diseases in many other settings. Dr. Lynch is an active statewide and national initiatives to prevent healthcare-associated infections and development of drug-resistant bacteria. His co-speaker is Dr. Steve Mitchell, who is the acting medical director of the emergency department at Harborview Medical Center, a UW assistant professor of medicine. Dr. Mitchell has a clinical and research interest in pre-hospital emergency care and emergency department clinical operations with extensive experience in disaster preparedness and operations. Dr. Mitchell earned his MD from the UW School of Medicine and did postgraduate residency training in emergency medicine at the University of Virginia, where he was the chief resident. He returned to Harborview at the University of Washington where he serves as the chair in, always love the page change, clinical care for the Committee on Ebola virus disease, patient care, and related operations. So Dr. Mitchell is a fellow in the American College of Emergency Physicians and a member of the Washington State American College of Emergency Physicians Board of Directors. So without further ado, we'll turn it over to these guys.
Good morning, and thank you so much for inviting me. I have to admit I feel a little nauseated talking about this topic again. But I'm going to give it my very best. As with a lot of the folks in the room, took a lot of time and kind of deviated a lot from our jobs, especially back in 2014 and parts of 2015. But my job here is to sort of set the stage using Ebola as a sort of a test subject for what happened here locally. So here's our objectives: to understand the complexity of safe and effective care, to understand the unique impacts on staff when caring for these patients, and understanding the fundamental shift in an institutional approach necessary for effective care. So I'm not going to put these things up and answer these questions specifically. I think the point of our presentation is sort of set the stage and to talk about why we're even using these objectives. So, Harborview, right across the street, for those of you not familiar with it, we're a level 1 trauma center. We're a designated burn and trauma center for the northwestern United States, so Washington, Wyoming, Alaska, Montana, Idaho, sometimes northern Oregon. For trauma, definitely. For burns, we're also a mission hospital, so we deal with specific mission populations, the incarcerated, the impoverished, immigrant, non-English speaking populations who don't have access to healthcare other places. We're highly skilled around things like shock and sepsis through Steve's emergency room, but also within our hospital. Our King County tuberculosis clinic is in our basement. We see a lot of TB cases here. We have a very large HIV clinic. We deal with lots of influenza. We were sort of prepared for highly pathogenic avian influenza as well with the facilities we have here. We have a fair amount of hantavirus up in the northwestern United States. We had a handle on that. And many other diseases. What we recognize through this process is that we are all these things, but we're also in many ways looked at as sort of the place to go when no one else wants to deal with these problems. And so we thought we were all prepared. And then obviously Ebola happened. And as all of you know, this was a simmering disease that was occurring over early 2014 in the spring into the summer, and really wasn't recognized by international public health authorities for a long time and didn't really make the news for a long time. By the time it sort of did make the news, it would spread through 4 countries: Guinea, Liberia, Sierra Leone, and Liberia. Yeah, so Guinea, Liberia, what's missing from here? So those countries. And it was an enormous outbreak by the time people got a hold of it. And what people basically got through the media, really importantly, sort of sets the stage for what happened to all of us. We heard things like 1 in 2 people who get Ebola died, so that 50% mortality falls right in the middle of what was quoted during that test. And people started talking about, where does this disease come from? This idea of bats and Ebola in movies, right? People bleeding from their eyes and getting exposed to bats really informed a lot of this conversation. So was that it was moving very rapidly. So as this information got out, we knew that Ebola was happening. People in the United States, I should say North America, for our Canadian colleagues, learned about this We were looking at what was happening, week 1, and then 1 week later where these lines were going. So rapid change in the number of cases in West Africa, so a rapidly expanding epidemic. And what was really recognized quite early, folks, and this is right from the New York Times, which you never think was going to make it there, was that this was the largest Ebola outbreak ever identified. So since the first outbreak many years ago, back in the 70s, scattered outbreaks through time, and this just huge outbreak going on in West Africa by the time it was even made it to the papers. On that same idea, we were getting data out from big authorities such as the Center for Disease Control here in the United States with projections of what would happen if we did nothing. So back in the fall, you guys probably remember looking at these. Back in the fall, October, November, so I should point at that one, which it doesn't really work. But October, November, we're back here looking at 10,000 cases in West Africa, 12,000 cases in West Africa. And if we did nothing, we're on this sort of logarithmic growth to hundreds of thousands of cases. And that's when people really started to pay even more attention. If we're dealing with 10,000 cases and this has become a global health issue, what happens when it's tenfold more cases? And that was the sort of projection if nothing was done. At the same time, we started getting pictures of folks like this, right? We're seeing transmission among many patients and, importantly, healthcare workers in this outbreak. We're seeing someone like this wearing this really high-level respirator, right? We just talked about how we all sort of know how Ebola is transmitted. Really, it's really contact. Yet you see this guy wearing this high-level respirator and no gloves, right, handling substances. And we're getting mixed messages because we're also seeing folks like this taking care of patients, right? They're wearing total eye protection, masks, their neck's totally covered. They're wearing, the gown out front here on top of the full body coverage there. And so people were very confused, not only the general public, but my healthcare workers as well. I was confused, right? Because at the same time, different health authorities were saying different things about whether this is closer to the right or that's closer to the right. You guys remember this? I think it's everyone, yeah, everyone's having little recollections here. Flashbacks. And then this happened. And Steve's going to go through this more specifically, that we have this. So we have these guys in these giant moon suits, right, as mentioned this morning, totally covered. And we have a patient with Ebola in the United States. And this sort of broke open the conversation quite a bit because we were hearing one thing about how to take care of patients, and this is what was showing up in the media, right? And this is, in places where CDC has some visibility. And this really accelerated the whole problem. And then we saw this. Now, who here who's involved in employee health and safety or environmental health and safety ever thought that PPE was going to be in the New York Times? Right? Whoever thought that people would be talking about the subtleties of this versus that, versus that, and what the differences are? And people became kind of informed about this. And so at the same time, people are seeing all that media stuff about what people are wearing in West Africa, what people are wearing in delivering patients in North America. We're having the CDC saying, oh, you're fine if you just wear, just get a surgical mask and a gloves and your gown and you're good to go. And that dissonance created a lot of confusion and a lot of stress for everyone involved. And so there was this evolution to more coverage, hoods that cover the neck, 2 layers of glove, food-resistant leg and shoe coverings, to eventually what we all sort of recognize in some way, shape, or form to this full body coverage. It may not be this full moon suit, but the amount of work that went into this transition when authorities are saying, do this, the media and Médecins Sans Frontières is doing this in West Africa was a big deal. And it really probably led to why we're talking about a lot of this today, because it was a huge challenge that really wasn't necessary in retrospect. I'm going to turn it over to Steve now, and I'll come back and talk to you about our specific response shortly.
And so what was going on locally in October 2014, and again, we want to illustrate using a case example drawn from Emory, drawn from Dallas, and drawn from our own experience to really illustrate some of the challenges and the whole reason why we're all here today and we've done this entire project. And so back in back in September of 2014 was when Thomas Duncan was first diagnosed. He was the gentleman who had come from Liberia, from Monrovia. A few weeks before this, he had helped a pregnant lady who he was living with, helped transport her from home to an Ebola treatment center in Liberia. And then a little bit after that, he got on a plane and flew from Monrovia to Brussels, and then from Brussels to Dulles, and Dulles to Dallas, Dulles in D.C. to Dallas. And there's controversy about whether or not he was symptomatic when he got on the flight. He claimed, while he was still lucid, as he later got sick, that he was never symptomatic, and yet there was lots of doubts in the media. But as John talked about, Harborview kind of has a can-do attitude about things. And we're used to handling complex cases. We're used to handling all comers, and wanting to kind of get out in front of what was going on. We identified ourselves as a place that was willing to take care of patients should you have concerns about Ebola specifically. And because we fundamentally thought at our core we were prepared. As John showed you the entire list, we can do this, and as we understood it, we thought we were prepared. And then, so this is on October 6th, and then 4 days later, Nina Pham, who's one of the nurses in Dallas at Dallas Presbyterian Hospital, got sick. She was the one who was taking care of Thomas Duncan when he arrived, and all of a sudden, we began to see some of the impacts and some of the trickle down and think differently about it. And about this, right about the same day, maybe a day or two after, John and myself and a bunch of other people from a true multidisciplinary representation of the operations across the street at Harborview got together in a room and started to talk through what it would mean to care for one of these patients. How do we handle the waste? How do we handle what do we do with the blood, with the samples and everything, and such. And it was I think it was a 90-minute meeting, and we realized we had hours and days of work ahead because it was so much more complex than any of us had appreciated. I know I walked out of that meeting at about 10:15 that morning, and with my nurse educator, one of my senior emergency department nurses, and we said, you know, we should probably go and look at our PPE. We should make sure we think we have adequate supplies. Let's go and let's just go through it. Let's look at the sizes. Let's see what we got. And so we started to do that. And lo and behold, a half an hour after that, we're down there just literally with our PPE out. One of our ER docs comes to me and says, just so you know, in 20 minutes, we have a gentleman who has just arrived from West Africa. He's got a fever, he's got a headache, he's got belly pain and joint pain, and he's going to be on the ramp in a white van, on our ER ramp in a white van in 20 minutes. You guys are ready, right? And here he is. And so one of the things we want to illustrate is that we decided right away we needed at least 2 nurses to be caring for the patient as well as a physician. There were 3 nurses who were eligible. And how do you think, and each one of the 3 nurses were very senior, hardcore, unflappable, tough emergency department nurses. Probably with a combined, you can't repeat this, but combined level of years of experience of close to 85 or 90 years. All of them were very, very seasoned. How did they make their decision about the 2 who would go into the room and the 1 who would stay out?
Who didn't have children?
You're exactly right. It was more specific than that. It was, you have the youngest children, you have more responsibilities at home, therefore you stay out. Okay? The physician, remember the guy who walked up to me and said, by the way, this guy is coming? We tried to put PPE on him. He has size 15 feet. We have no, and he was too tall. When we actually put the gear on, it went up to about mid-thigh on him. And so this young man, who's one of our physicians, was just walking by, and now he's in the room taking care of this guy who has presumed Ebola. And we're hearing about all, and this is all when we're realizing that healthcare workers are getting sick. And so one thing that's valuable also, I think, is the narrative portion of what was coming out of Dallas at the time. And this is taken from a 60 Minutes transcript of some of the key healthcare people who were taking care of Thomas Duncan and primarily Thomas Duncan. So on September 28th, Duncan was rushed by ambulance to Texas Health Presbyterian Hospital. He was isolated in a separate section of the ER, and nurse Cydia Rose started the night shift. So Cydia is showing up for her night shift in the ER just like she always does. She was briefed on the special precautions required for what they now suspected was a case of Ebola in their emergency department. Cydia Rose, I went over and I met with a nurse who gave me a report. She also went over the protective gear that we would be wearing that night. She gave me, she kind of finished briefing me on what was going to happen, and what did I do? I literally burst out into tears. These are usually really unflappable people who see some really tough stuff and take care of some tough stuff. This impacts you in a way that we did not anticipate. And so we are realizing in real time that risks really abound and are multidimensional when taking care of these highly infectious pathogens. And so when you factor in the reality of transmission of EBD to staff, when you realize that that a single patient can literally bring your hospital, a major hospital, to its knees, and has significant impact in every single way, as well as financially. And so one thing we're also learning as well is we can't underestimate the fear factor with all of this. And it's not paranoia, it's not educated versus uneducated. This is a different level that people experience. How many people, we all thought, I assumed that everybody would show up for work and take care of this patient should we have an Ebola patient here. And as we actually began to go through and talk to people, we realized that some of our physician colleagues, they're not going to show up to work that day. They did not sign up for this. If you're in the military, if you're a police officer, you accept that sort of personal risk, and yet physicians were saying, we don't think we're going to be doing that. Nurses are saying the exact same thing, and yet Harborview, the culture of this place is it's a can-do, we can pull it off, we're used to take care of complex things. This was different. People were literally not going to be showing up. What about the support staff? The support staff are typically folks who aren't necessarily as educated, have an incredible kind of can-do, I'll show up and do the work attitude, but as we dove into things and what they would actually be doing, we were asking our least educated, least trained people to be doing some of the most hazardous work, because cleaning the rooms, transporting the fluids is some of the most hazardous work. Did they sign up for it? Are they going to show up to work? And what about patients and families? So indelible in my mind is the look on the family's face who was from me to John away from where our patient from West Africa was in our emergency department as we're trying to sort of cordon things off, and yet they're looking at us going, what is happening in there? This looks fundamentally different. And do you think, when you talk about risks to the hospital, do you think if you have a choice between Hospital A and Hospital B and Hospital C, you know that Hospital A has a patient with Ebola, that you're going to show up and actually go and want to get services at Hospital A? Realistically, no. And hospitals in the United States, for our friends from Canada, operate on an unbelievably thin margin. It's plus or minus 1/2% oftentimes, most oftentimes. And so all this is in the context as well of all the reports coming out that are saying the threat to healthcare workers is real. Roughly 50% of the patients of the healthcare workers who get sick were dying. And so this is a graph showing, there had been over 800 healthcare workers who had been infected, and of those, almost 500 of them had died at this point in the process. The threat is real. So looking back to City of Rose, the first time when I went in and he vomited, I was standing in front of him. He was sitting on the commode, and there was so much that it went over the bag. It was on the walls. It was on the floors. I had 2 pairs of gloves and shoe covers on, and I had my face shield on. I didn't have 2 masks on at the time. I just had one. No, we didn't have any head covers, but I wiped down the walls and wiped down the floor with some bleach wipes. And these are really good people who are trying to do the right thing at the time. Richard Townsend, he was having so much diarrhea and vomiting that she was just constantly having to give him the little bags that we have people vomit in, the little green vomit bags. So and everything coming out of him is incredibly infectious. So risks to the hospital. Then the hospital moved out all the patients in the medical ICU and reconfigured a 24-bed unit for just 1 patient. So again, hospitals in the United States operate on an incredibly thin margin. Now you have shut down your entire ICU for one patient. It was a strange scene for ICU's John Mulligan. Dallas Morning News. Texas Health Presbyterian, what happens to them? In the weeks and months afterwards, revenue dropped 25%. Visits to the emergency department plummeted by half. Risks are real. Then we started getting information as we started to coordinate our efforts out of Emory. Emory, who had actually taken care of some real patients. And if anybody in the country is prepared, it's Emory, right? CDC is right there. They're a recognized center. Patients are being flown from around the world to them. They put out some of the challenges they were having. If a lab specimen spills in the main lab, we would have to close the lab down for hours to decontaminate. A lab is a central hub of activity in a hospital, and so essentially diagnostic capacity for your patients stops for hours. That would another enormous impact to the hospital. If a lab specimen from an EVD patient comes to the main lab, they admitted few of their folks down there would actually run the specimen, would actually deal with it in the beginning. There's some, what about dealing with the waste? The CDC, the feds are saying sanitary sewers are just fine for the safe disposal of patient waste. But when Emory went and talked to the folks who actually managed the pipes coming out of the hospital, they said, that's fine, but we'll just tell you that if Ebola virus is placed in the sanitary sewers, we are going to disconnect the hospital. How do you run a hospital if you can't flush the toilet? So what did they do? All patients with liquid waste were disinfected with bleach or quaternary disinfecting detergents for 5 minutes prior to flushing. Here's another example. CDC says disposable materials and linens should be placed in leak-proof containment and discarded as regulated medical waste. So similar to how, to HIV or hepatitis or whatever else, we put it in regulated waste. And yet, when it came to this, the contractor says, what? Well, that's fine, but you have to certify, tell me how you certify this, by the way, that there's no Ebola virus contained in it, and then we will take it away. So what they do, they autoclaved everything and before it got picked up. And we knew, this is probably not going to show up real well, but we did a survey, Dr. Wong, who's over here, and myself, we surveyed emergency departments across the state of Washington about the challenges that they were having in the midst of this. And what was encouraging, what was interesting, is that there was a lot of different challenges people were having, but the good thing is that your biggest challenge usually, the hospital administration, was the least of your concerns. It was all the other things that were going on. And yet all the, nearly all, or about 80% of our emergency department medical directors in the state all said a single patient with Ebola would bring them to their knees and their ability to operate their emergency department and take care of patients. And so we learned that we had to take a fundamentally different approach to handling this. And we think moving forward, this is fundamentally how we are going to change our approach with highly infectious disease care, and that is we are going to take what we've learned from our disaster scenarios, and we're going to call this what it is, which is a potential looming disaster. And we are going to, and what we did is we brought together our hospital incident command system and in an organized approach assigned roles and responsibilities throughout the hospital, because the risks abound and it affects absolutely every person from start to finish in the entire hospital. So John,
Any questions so far? Flashbacks? Yeah? Yes?
How do you manage information flow to the press about this? Because it seems like if everybody knows you have an Ebola patient in the hospital, it's very different from everybody not knowing that you have an Ebola patient in the hospital.
Yeah, I mean, I think if anyone, it's a good question.
Can you repeat that question?
Certainly. So the question is about how to manage media and how we're perceived by the public at Harborview. So you can see when that came out that the CDC contacted us about being a potential Ebola treatment site. We said yes. It was in the papers the next day, followed by a press conference with Public Health and Harborview and the state out there. So I think we have a very effective communications group here, and it was through that close, and it's part of the incident command structure is that they were part of all of our meetings, and we were very aggressive about every media request. We did it. You know, I was on all the local media stations. I was in the paper, just talking about it constantly, all the time, and basically trying to really say, you know, we were prepared. Here's what we're doing. Here's what's going next. And because I think we were able to also base it some of our experience around, you know, big mass casualty events, serious, you know, burn events, and other unusual things that we've had to deal with here at Harborview. We've had some experience with how to do that, and so I think it actually worked out pretty well. There was definitely concern in the community, but we really tried to stay out in front of it and answer those questions.
The downside was that John and his teammate were a key partner in the overall operational issues, and we were literally having problems. This man was working 23 and a half hours a day for a month because of all of the different issues that were going on, as well as the media requests. But we felt it was also important to have consistent people with that messaging.
Yes.
I would like to say that there's also a challenge with social media too, because sometimes the patient themselves is disclosing and posting things on Facebook or on Twitter accounts or whatever, because we had somebody who was a suspect patient in Kelowna, in British Columbia, and they posted on Facebook a picture of themselves in the room being isolated and everything, so
Yeah. I think
hard
so.
to control.
I think you're absolutely right. So the point was being around social media. You know, we can't control our patient messages, but what I would say that if that patient gets into your ER, it's within hours, within an hour, it's going to be out.
So
Regardless of whether it's on whether it's on social media, it's going to be someone working there is going to say something to someone. Our expectation is that as soon as someone came into our isolation unit or in their ED with this suspicion, that it's public. And so we were prepared at that time. 100% we knew it was going to happen every time. And there's no reason to keep it a secret, honestly, right? So we were prepared, we made the message, and we sent it out.
Just something I think that makes Ebola different, unique, is it's not necessarily very contagious, but it's extremely infectious.
Right.
And that distinction is really important to understand when you're trying to protect your employees, is that, you know, if you are exposed to a single virus, you may get the disease, as opposed to, say, AIDS or other things where it takes multiple, virus or, but it's not that contagious as something like measles would be.
Right.
And that's, I think, what made this especially unique.
Well, I think you're absolutely right. So the point is that this idea, you know, Ebola is, if Steve has Ebola and I'm standing here, I'm not going to get Ebola, right? It's not going to like jump off of him and jump onto me. if I'm interacting with him, right, that creates a risk. But just like, it's not like influenza, right, which we deal with all the time. But, you know, how to get that, sometimes if you start delving into those details, the messages sort of got mixed, and sometimes felt like you were trying to devalue or turn down everyone's concern. And so you're absolutely right. I think there were some attempts around to deliver those types of messages, but sometimes those subtleties, when people are like, you know, I'm not going to come to work. Like, who's going to take care of these patients? What about, you know, all these other big issues was even much bigger for us at the beginning. Yeah, daycares, you know, it was just insane. And there was another point I was going to make, but hopefully I'll get to it here shortly. Any other questions? These are good questions.
So was there any thought about, rather than, you know, the typical big, well-staffed hospital caring for these patients, whether a small hospital so that it wouldn't impact the rest of the hospital operations?
I think that's an excellent point. So the question is about, you know, should we use like a big central hospital that has a big, highly qualified staff compared to maybe a community hospital with, you know, community hospital staff? We did think about this, right? So my hospital across the street, that one, Harborview, we're a 413 bed hospital. We have about 98 critical care beds, so about a quarter of our beds are critical care beds. And we have anywhere between 20 and 40, 60 people boarding in our ED on any given day.
33 this morning.
33 this morning who are waiting for a bed. And that's every single day for the last, I don't know, 3, 4, 5 years. Every single day we're over. We're at 110% every single day. So the question is, well, I got to take care of burns, trauma, our mission populations, everybody who walks through our door, our elective cases, right, when I have no beds. And this person potentially could take up a lot of resources and a lot of space. So maybe they should go to a different hospital. Most community hospitals are usually running 65, 70, 75% capacity. But that also means their FTE isn't staffed above that, right? And so we did have conversations around there. There are places that have, you know, half full ICUs. Should that happen there? And for us in our system, it ended up not. We did discuss that, and I think it's still a worthwhile discussion. But in terms of the kind of expertise around it, for us, what worked was the culture at Harborview. Steve calls it, you know, the can-do culture. It's just the Harborview culture here worked really well to get this done. And we also had the resources around all the other planning that was part of that. And we have the experience with, you know, MERS and SARS and influenza and TB that, you know, other places may have some of, but we just had more, right? Right in the middle of this, we had a MERS admission too, right? So, any other questions? Those are great questions. So this is Harborview, as I mentioned. I sort of gave you a description, and it's right across the street. And as we had these discussions and all that meeting is going on, we started developing this incident command structure, right? We were recognizing that we needed to be more thoughtful. Yeah, we talked about the ED, the person pulling up on the ramp, but I actually had a lot of ways to get into my hospital, right? We have people coming in to specialty clinic from all over the world. We have people coming to the pharmacy. We have our morgue. So the county morgue is right across. It's actually in this building.
It's actually in this building.
And they bring in people from all over the place, right? Found down at home. We have our emergency departments where most of our admissions come through. Front door, you know, we have people coming in from community sites, off-site clinics, you know, coming in for an imaging study, coming in just to get labs. We have, you don't see it on this side, but we have 3 helicopter pads in the back, right, which are going on all the time. So I have people coming in from all over the Northwest, landing here and coming in there, and with fairly undifferentiated diseases. Sometimes this is straight up trauma. A lot of times it's just super, super sick at some other place. And so we recognized very rapidly this need for the incident command structure, because I had to address all the things things I knew about, but more importantly, the things I didn't know about, right? So much Donald Rumsfeld only said one smart thing in his life, and that was, you know, the unknown unknowns, right? And that's the truth. There's no known unknowns, unknown knowns, but the real one is the unknown unknowns, right? And so, you know, here's our ED entrance. This is Rusty, one of our amazing engineers. We couldn't have done what we did without our engineers. Could not have done it. and with specific individuals within our engineering group. This is Rusty. He can make anything. This is our entrance. This is where that ramp was. And basically our engineer guy said, you know, we can make walls. Just tell us where you want them to be. And so this is a door into our what's called our ISO blue room. It's a negative pressure room where that patient was put in. And we recognized if we're going to have patients coming through the ED, we need to have a hot zone, cold zone, warm zone. And these guys said, yeah, we can build it. Just tell us where you want it. They put up these things, and then they basically kept the structures together, and they could just whip them up in like 30 minutes, 45 minutes from the time I say go. They'll do this 24 hours a day, 365 days a year. They'll throw up these walls. And these had nice zips in here, and they were all sealed above and below, and you could have this as your kind of warm zone as you exited. And it was amazing to watch these guys work. Here's doing it up in our ICU. So this is actually a long corridor. This is one of our pods in our neurosciences ICU. This is the public corridor right here, and there's a room right here. And this is our first negative pressure room. This is Deb Metter, one of our amazing nurse educators. Some of our admin folks. We have like a food room over here, an empty closet room, and everywhere where these lines are, you can see these poles is where they put walls up. Here's a wall closing off the corridor, and basically turn these two rooms into our treatment site. And again, I could say, hey, engineering, we got someone coming to be here in 45 minutes. They had all these lines down. They could come up here. They would just, all the guys would show up, throw up these walls, and everything would be up and rolling in probably 45 minutes to 50 minutes. They could get, the patients into this room, and then they'd come and build it behind them if they needed to, right? So that incident command structure, building, planning, getting everyone on board, figuring out how to do this stuff, timing, personnel, worked extremely well for us. Here's the inside of our warm room, so exit room, just again, the same thing. A lot of training. Here's Deb Metter again. Her and Vanessa McCarowitz were really leading on how to go about training these things. This is not stuff that people were used to doing, right? Even, TB, yes, we know about N95 respirators and purified powered air respirators and so forth. But putting all this gear on in the exact sequence, right, and getting it off in the safe way was a totally new process. So we had to do a ton of training. And remember, that 0.5% margin, this was totally unfunded. We just knew it was going to happen. And this was an enormous amount of time for trainers, but also for all of this is one of our nurse managers, right? She's got a unit to run, a big medical cardiac ICU, but she's up there getting trained. This took an enormous amount of time. At the same time, when all this stuff's going on around, well, if I come in, I don't have to go home, right, to my kids. If I take care of this, am I going to put me in a hotel? All that media stuff's going on, and all those pictures are showing up. So, I'm an infection prevention doc, and so I deal a lot with the environment. I deal a lot with my engineering colleagues. I deal a lot with my safety officer here in the front row. But I learned even more about, where water's going, where air's going, where waste is going. We had, as Steve mentioned, our environmental services folks, when we first said, okay, all you guys have to do, we'll take care of all of the waste, but then you're just gonna take the big locked bucket and just push it down to our other place, right? It wasn't until we did a drill, and I have that EVS guy who's coming in, just a drill, nothing's going on. He goes over and he gets that thing, and the sweat is coming down he was so nervous in a drill to move these materials around that it became just abundantly clear to me that this was not the right way to go, right? He didn't understand this. It wasn't fair to put him in a circumstance where he didn't fully understand the risks, very, very low, but to him, very, very real. And especially with all the media going around, right? That we were trying to manage, but we weren't controlling, we can't control completely. So we ended up building, this is so this is our ED. So here's our ISO blue room. So patients would basically come in from here's the ramp. They would come in through this cold breezeway. There's that temporary wall. They would go directly in. We had an anti-room for cold, exiting warm, and a shower over here as another cold room. So people would doff all their stuff here and then scoot across our main entrance to our emergency department, where all of the rigs dump off all their patients, right? Scoot across there, take a shower, and then get back to work. So you can see a lot of issues here, but there was no other opportunity to move anywhere else in our emergency department. Here's our upstairs room. I just showed you that. So here's that long corridor. Here's that public corridor. And this worked really well. So everywhere there's a black line, we put in walls. Here's the same thing. So we actually go into the hot room. We have nice windows there. I'll show you a picture of. We have a warm number 1, a warm number 2. They scoot across the corridor into a shower, and they can exit out into the corridor. What worked really well here was when we started recognizing that we would know about patients coming in from a clinic, coming in from an outside institution, is that we would basically build a bypass through, just skip the ED entirely and go right upstairs. And what was amazing about this, we get our guys up there to build all this stuff, sometimes build it behind the patient, put the patient in the room, start providing clinical care. We would close this door and total quiet. It was as if nothing ever happened once we got them in there. A lot of work going on in here, but because we were able to close off this area and have this good, really good safe zone in here for taking care of patients, we were able to close it off and no one knew what was going on. Again, we were delivering the message, but right there and then, no one's walking by, families aren't walking by. Our ICU family information desk is right there, right? So we had to give them a message. What do people say when you're doing all this stuff? What do the volunteer person at the front of your patient relations desk say? So making sure all those messages are consistent. We had to figure out how to get people from the ramp all the way up to our ICUs, so dotting out exactly. And then what do you have to do following? What happens if the person throws up on the way, right? What happens if the person, doesn't do well on the way? What happens if they lose their airway? All those things. Who's going to follow them? What happened? All those steps were really challenging, but we were able to use this incident command structure. All the folks who were able to do that, engineers were able to build and figure out where this is going to go, security clearing corridors, so it was planned down to a T every time. Here's one of my infection preventionists, who's also a nurse, who was able to watch our doffing team on the exit. So again, here's our walls. Here's where we ended up. She's not very tall, so you can see it actually, she got full coverage there, so it was great. Here's a taller person, very well covered. So in the end, it all worked out really well, but it was an enormous amount of work to get it to happen. Here's one of our patients we were taking care of. As I said, so this is the room here. Here's our windows. Here's Tim Dellett. Here's Larissa Lewis, one of our nurses. And this is actually one of the public health docs. And they were on site, too. We're a very strong partnership here. We're lucky to have strong public health partnership. And they were able to participate and figure out in terms of risk assessment and communication. And here's one of our patients just being ruled out. One of the big parts of this was around the team dynamics. So all of the folks who took care of patients who were being ruled out or actually had Ebola recognize this. When you go into a room and there's 2 or 3 healthcare workers, healthcare workers, nurses and docs, want to take care of patients, right? You go to a nurse and say, you can't touch that patient because the physician is touching the patient right now. Or you go to the physician and you say, your job is to be quiet, stand away, and watch the nurse and make sure he or she is safe. Those things are really hard to get through, right? Because the physician wants to go up and do an exam and do their normal thing. The nurse wants to be doing the lines and stuff. And all of a sudden, the dynamic had to be totally broken apart and step back and say, this is a team approach. If the nurse is doing something, everyone's off. Nurse does his or her thing. The doc's job is not to do clinical care, but to watch that nurse and make sure everything's staying safe. Make sure there's no break in PPE or exposures, right? And then it switches. The other thing, little things like stethoscopes. So what we ended up having was little Bluetooth scopes that the physician would use that I would listen to on the outside. And then I'd give it a thumbs up, thumbs down, sounds good. And then I would kind of tell that part of the exam. Because he wasn't doing the exam, he was just holding the scope to the heart and the lungs, right? Because you can't put earpieces in.
Yeah, earpieces in.
Right? And so it's all these little things. So it was a total team approach to taking care of patients. And we learned this very fast. And there was more work. What happens if the person needs dialysis? The Emory situation, I think Dr. Crozier, who's been public about this, I think he needed dialysis, or one of the other Emory victims. How do we handle dead bodies? The most contagious time, infectious time, whatever, I'm interchanging the terms here, is this situation. How many bags and how many wrappings do you need to deal with this? So we had to talk with our colleagues in pathology and how to handle bodies. We had many meetings around that. And then what happens? How do you get them off campus? Monitoring of laboratory workers. So what happens if you're a laboratory worker and you do come down with symptoms, right? It's not a clinical person. So we don't think about our laboratory workers and their exposures in the way that we think about our bedside folks. Big work around standardization of PPE. And how do we maintain this training? Because now we're in it. We're all here in it. Ebola is still cooking. This is exactly what we thought was going to happen, right? It didn't get as bad as we thought it could be, but it's become what we thought it is, which is an endemic disease, right? We're going to continue to see cases cooking through West Africa and maybe other places indefinitely. I virtually guarantee there's always going to be some cases. They're never going to be Ebola-free ever again. And so how do we maintain this training? Again, funding, time, effort, when there's other things coming down the pike, right? So we all did this, and then fortunately the CDC showed up the next day after our first admission to evaluate this. Worked out really well because we had just run through we had our ultimate practice. And then, there was this whole response tier process. Spokane, I heard someone here from Sacred Heart, right? Yeah, so you guys are familiar with this process as well. For those of you involved in the United States, there was this sort of tiered process. Are you a frontline facility, more of a community site that has to recognize someone at risk? Are you an assessment site? So I think it was sort of, can you take care of a patient for 3 days or something? And then Ebola treatment site like Sacred Heart or Harborview and some other places where you can take care of a patient indefinitely throughout their thing. And so, again, the rapid evolution and the ability to use incident command structure to respond to this rapidly changing environment was key. So here's some key actions, right? Rapid development of safe, effective protocols. Always be ready to say, yes, you're right, I'm wrong, let's change it, right? That was a key part of this. Communication education. You said to the media, messaging our healthcare workers. So I spent a lot of time, I never laid hands on a patient who had suspected Ebola, right? That wasn't my job. My job is all the stuff around it. But I spent a lot of my time doing town halls, giving lectures, talking about it, over and over and over again. Going to Airlift Northwest, going to Alaska Airlines when one of the nurses was on the plane. All the airlines got, frightened. The folks who owned that plane who transported the nurse, you know what they did? They landed that thing and they stripped the inside. They took out every chair, all the rugs, everything. I mean, just the way people responded to things. But this, you cannot overly communicate, is what I learned. Training. This is probably true for many things, but when you train a lot and then you go and do it for real, it feels much more normal. So training is such a key part of normalizing the work. It becomes much less frightening when you're used to the equipment that you're using. Be ready to modify all the above on a daily basis, right? When the New York Times publishes something or another situation happens, again, I always come to this with, I'm wrong, you're right, let's look at the evidence, let's do it, let's fix it, make it work. And we're fortunate here to have a staff that is very responsive to those types of things. And then preparing for the long haul, because Harborview is a trauma hospital, we're a burn hospital, we're a mission hospital. We are clearly in our area an infectious diseases hospital, right? We didn't identify that way before, but if you show up in a quarantine by CDC at SeaTac and there's a problem, you're coming here, right? If you show up at a community in our area with a concern for SARS, MERS, epidemic X next, you're going to show up here. That's just the way it is. And so we have to be prepared constantly and prepare for the long haul, because there's always going to be something. Anybody who's been in healthcare for the last 10 years, SARS, MERS, right, Ebola, highly pathogenic avian influenza, these things are going to happen. Something else is going to happen. And we've used many of these things for the Zika response as well. Zika is not the big infectious disease concern, but it is something that's important to patients who are at risk. And so how do you identify folks up front? We can use parts of this to apply to that problem as well. Yes?
So, in regards to communication and education, you made the comment that you can't communicate enough.
Yes.
But have there been any concerns or thoughts around what we would consider communication fatigue?
On whose part? Mine?
Well, that too.
Yeah.
But one of the things that we've been concerned about is we have a number of physicians. We come from a system that has 22 hospitals.
Mm-hmm.
So we're not concentrating on one, but all 26. And one of the things that we're trying to figure out is, yes, we want to communicate, but what's that fine line? Because physicians, and I'm not going to just say physicians.
Go ahead.
But,
Yeah.
okay, physicians.
Yeah.
But, you know, it's like, do they read their email? They'll say they never got it when you sent it, because they're they have thousands of emails that they deal with. So how do you,
I think
has that not been a concern in terms of communication fatigue, or?
I would
really
say,
trying to get-
let me see if I'm answering your question right. So the question is around communication fatigue, and what I think you're asking is, well, I'll tell you my answer. And that's that we did have some of that, what I would call dissonance, sort of media dissonance. So we had people within my university community who have experience from the basic science perspective around Ebola, who were sort of sending out messages that I thought were counter to our approach in our response, and actually to what I thought were the facts. And so what we recognize is that we really can't have a scattered media response, right? We need to have a unified, planned media response. And so the message was, you know, we're not going to penalize any healthcare worker for saying something, but the message was, we have people to talk about this. Just hold tight. If you have concerns, let us know, but we have people to talk about this. Let's focus our message on that 1 or 2 or 3 people and let them do all the talking. And I think that worked really well, right? And we're able to sort of deal with the dissonance that was existing, get that kind of shut down.
One more quick thing also is we also realize that there's, in order to control the message and the training and the consistency that was required, and to find out who was willing and capable and able and all the messaging that goes around that, we began to limit the who was actually going to be providing the care for the patients as well. Different challenge, much easier to do in the ICU. In the emergency department, where you're a 24/7 operation, much more difficult. But basically, we had identified 3 of our emergency department physicians also, who said, we're gonna be the point people while we train everybody else up, because we know we can provide that safe consistency and control the message as well. But anyway. Yeah,
So real quick, regarding messaging, if you're going to ask questions, please use the
Oh, yeah, sorry. Use the microphone.
Yes, it is. So we have a biocontainment unit in our hospital, and we've been doing a lot of work on getting up to speed since the outbreak started back in 2014. Well, the outbreak here anyways. Our physicians have all been involved in doing the training and the simulation, and it's been really, really good because the communication has been all on the same level. There's no hierarchy, there's no, and it's all been, just like this slide is perfect about, when the team they're the ones that are going to be exposed. Mm-hmm. They're the ones that are going into the danger zone, and both our physicians and our RNs, our RTs, respiratory therapists, and also our medical imaging technologists, they're all volunteer. Mm-hmm. So I don't know if you guys are operating on a volunteer system or not.
We are.
But yeah. So with that, and then what we've done through our simulations is you don't know what you don't know, and it's through simulation it's really been incredibly helpful. And what we did is we have observers in each room and writing down every issue that came up. And when we first started doing simulations, we had about a stack like that. And then we had to go and address each and every single little thing of this. Something simple as there's not enough clocks in the room because you've got a poor vision, field of vision and all that. So, and then we got down to very, very little. And then with the training and everything, everybody's feeling a lot more comfortable. But I'm wondering, what is the frequency of your training in your emergency department and in your ICU? And are they 2 different teams that care for the patient?
Yeah, so we do have 2 different teams, because in the ED we need to train a far larger group of folks for the person who would show up at the ED front desk. So we had lots of nurses being trained and lots of physicians being trained. Our upstairs it's a much smaller group. It's a large group of volunteer nurses, mostly critical care nurses, because we can often find backups for them from other units. if they get pulled while they're at work, and a small group of critical care physicians, hospitalists, and anesthesia providers. And so they're like our main physicians. And so it's a much smaller group. So our current training frequency is, I think we're doing it quarterly now, maybe a little more frequently, but well, in the ED, I'm not sure what it is in the ED right now.
We're speaking frankly, maintenance of this is a very difficult thing, and so we are doing it's essentially annual PPE training, and what we have philosophically tried to focus things down to a smaller cadre of people. So we broadly train people in kind of acute management, getting them isolated, staying safe, while folks come to the emergency department. And frankly, a lot of our operational focus has been to say, hopefully 100% of the time we skip the emergency department and go right to the ICU because of the testing reality that we currently live in. If we try and determine before they ever arrive on our campus how long they are going to be with us. And if they're going to be with us longer than 3 or 4 hours, 6 hours, we'll go straight to the ICU.
Yeah.
But our training is yearly, and a small cadre of folks are doing things in a more focused approach.
And upstairs a little more often, but again, you're dealing with time, getting a bunch of very important people together, nurses and docs, to take time, and it's not just a quick little refresher, right? It's got to get everything on. Some of it's new, it changes. So it's kind of that balance. Yes?
So just aside from refresher on the PPE on your quarterly training, what else is involved in that training?
You mean like in terms of updates around infectious diseases? Or?
Yeah, so do you just do updates, or are they simulating workflows, or is it just putting on the PPE, donning and doffing?
The focus is really on PPE, donning and doffing. We're fortunate to have a really strong education group as well here, and so what we've also found has worked well for us is kind of for that group of trained folks is just-in-time stuff as well. So we do a lot of, you show up at the door, let's go over this again, here's our process. Because one of the things that's hard to do is the specific team dynamics. So we do some team training, recognizing, like I said, if one person's touching the patient, the other person's job is to watch that healthcare worker. But making sure that communication happens, kind of like how surgeons do at the beginning of a case. Hi, my name is John, I'm your I'm the orthopedic surgeon. Hi, my name's Ted, I'm the anesthesia tech. Introducing everyone and recognizing who's going to go first, who's going to go second. And so some of that just-in-time stuff has worked really well for us.
Just a quick one. You haven't talked so much about what happens to lab samples. What does happen under these circumstances? How does it differ from your normal operations?
Sure. And I think I've got 2 minutes and 30 seconds to go.
Repeat the question.
Yeah, so the repeat question was, what do we do with lab samples? So this is a huge issue because even if everything goes perfectly, the machines have to be cleaned. And that takes about an hour. So you're shutting down hospital lab machine for about an hour, right? And we run 20,000, 30,000 samples a day. So it's a big deal. So the way it worked was for samples being brought down to our laboratory, right? There's kind of a couple of paths from there. There's going to be lab samples that are going to be dealt with, and we identified a series of lab tests that would be allowable in our facility, right? So complete blood counts and chemistries, blood cultures, malaria smears, really, really important, right? Because if we get that malaria smear and it's positive, we know what's going on. You got to get that done very early. And this is where one of the community hospital issues comes up, is actually on that one specific thing. If you can't get a rapid malaria test, you are doing your patient a disservice. And if you don't have that access to a test, that kind of takes you off, as far as I'm concerned, takes you off the list. So we have great malaria diagnostics here, so getting that early malaria smear really early is really important. So we had a list of things. The way it worked practically is I said, okay, we had a paging system, so getting your telecoms people involved. We had big page, hey, we got a potential patient coming in as a first blanket page, and then the next page, the patient's definitely coming. Then we have a big group meeting using our incident command structure, right, with incident commander running the meeting and what's the plan. We had the clinical team and we had sort of the backup, the whole systems team. And then the laboratory folks were involved at the very beginning. So the person who's on point for laboratory medicine was called immediately and knew what was happening and activated the laboratory response. They would designate who was going to work on samples and the machines that were going to be used. And then the actual transport, once the samples were obtained by the nurses at the bedside, those samples were put into the specified level of bags and specific boxes. Those were all sealed. We had a specific handling process for getting it from the room to the warm zone, walked down, and then to an external person out in the corridor. And then we would call, and then me or Vanessa McCarowitz, or both, actually we had two people go at the same time, would carry that down to the laboratory. They had the doors open. We would walk in. They'd have a person prepared in PPE to take that material and then start processing it. And so it was and they had it all cordoned off as a place to work because they wanted to make sure if there was a spill, they were able to deal
And
with it.
how do you actually test that for Ebola?
So the Ebola samples, right, were specific tubes, and then they were transported to our state lab, which is in Shoreline.
So you didn't actually do
No.
Ebola testing here on site?
Nope.
No.
No. So all that testing was done at our state lab, which is fortunately only about 20 minutes from here.
So total time from sample acquisition to when you had a identification or presence or absence of Ebola would have been?
Usually within 4 to 6 hours. Maybe 6 hours. It all depends on, but they were willing to do it for us 24/7. So we got lucky, you know. I think I'm in the red now, but go ahead.
I was just going to say, I think another important thing, and I'm sure you all did this with lab, we did a lot of discussion about what labs you would actually run on a patient.
Yeah.
And, you know, saying that you wouldn't, you're not going to be running your CBCs, your PTT, you're going to really limit. And I think that helped isolate in terms, at least in our lab, in terms of one very small area of the lab versus the entire
We
lab.
definitely we made a list of available labs. And that's what the labs we were sticking to, because there were some that, couldn't be done. And it was also recognized in what we thought was happening. But I'll just come back and reiterate, you got to be able to test them for the stuff that they most likely have. You know, do they have typhoid fever? Do they have, I've seen patients in North America get hospitalized, get tested for Ebola, and not get treated for the malaria. People have died getting ruled out for Ebola in the United States, right? Because they didn't get treatment for what they do